Welcome to Live from One Cancer Place. I'm Sarah Kelly. Today on Live, our own Dr. Chris Heery, Chief Medical Officer at Arcellx, is joined by Dr. Sharlene Gill, a GI oncologist and professor of medicine based in Vancouver, Canada. Sharlene has over 20 years of experience as an academic medical oncologist, trialist, researcher, and educator with numerous publications and teaching engagements to her credit. She is currently the GI Disease Site Chair for the Canadian Cancer Trials Group and leads the Canadian Association of Medical Oncologists as president. Recently, Dr. Gill presented a wonderful TED Talk entitled How to Flip the Script on Cancer, which demonstrated her passion for patient advocacy and empowerment. Thank you to our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. Dr. Chris, it's all yours.
Thanks, Sarah. Dr. Gill, thank you for joining us. We're so happy to have you. This is one of those unusual, occasions where we are inviting somebody along to talk about their expertise, and it is actually directly in line with what we have been trying to accomplish here within this community that One Cancer Place aspires to be. So could you give us just a little more background on how this became an area of interest for you and how you're approaching trying to bridge that gap for patients?
Thank you. So firstly, thank you so much for the invitation to chat today. And I think I agree, we're used to having conversations like as cancer experts about cancer, but more the science and the treatments, and certainly that's my comfort zone, honestly, when I talk or engage with people. So this really, I think any of us who have an interaction with patients learn from our patients, right? And it's one of those things. I think when I went to medical school many years ago, 25 years ago, it really wasn't a part of the curriculum to talk about the patient perspective or patient experience. It was very much focused on, learning what we need to know to practice medicine. And so I've learned a lot from my patients. And so this is my 20th year in practice. And I think I kind of came to this, you learn, and when you're teaching students and residents, we share those learnings, right? It's the art and science of medicine. And a lot of that is, and what I've learned from patients is really how they are, we talk about patient-centered care, but I really think of it as patient-driven care. Like they are really driving what we do, and their questions, their engagement, their own sense of advocating for themselves, I strongly believe changes outcomes. And this is not unique to oncology. I think this is in all of healthcare, but in oncology, it's, I think, particularly, personal to me as an oncologist. But I think in oncology, there's lots of choice, I guess, and patients really need to be aware of what those options are. So that's my long-winded way of saying, I think, patient advocacy is near and dear to anyone who's a clinician. For me, honestly, the TED Talk was, it was a consequence of the pandemic. Like, I think a lot of us who are practicing medicine in the pandemic were getting pretty exhausted, and it was challenging. And I needed to kind of pivot my thinking to my why, like, why am I doing this? And how do I find the joy again in what I'm doing? And for me, it was this TED Talk, and kind of like articulating some of my thoughts around this was a way for me to recenter. And here we are.
I think it's it's a topic that I think patients can attach to very easily because it meets them where they are. But it's not, like you said, it's not one that you hear many oncologists engaging with, right? I mean, the why is there a disconnect in the understanding of what we think we've conveyed to patients and what they are hearing? It's funny, something you said really just triggered a thought for me, which is that I happened to go to a medical school that was primary care focused. And so a lot of the things that we did early in our training were focused on trying to understand the perspective of the patient, which I now know is fairly unique. But, I also think that that's something that is very easy to lose as you go through more and more deep training and very, very specific science, is that it's hard to remember the words that you didn't know 8 years ago, like that you never even knew what those words were. Yeah. And now you use them so conversationally with your colleagues. And then you go into a room with a patient and you just don't know another word for that thing. And you have to actually sit down and think about what you are going to say if you want to be able to convey it. At least that was my experience. I don't know if you've had a similar experience, but one of the things I loved to do with patients was at the end of the conversation to say, now tell me what I just said. And it was like maybe 10% of the time, like in their own words, they could convey sort of like the most important points of what we talked about. And then we'd have to kind of start over again. And I don't know if you've experienced that, or like, having had, more time and experience, if you figured out some tricks to navigate that. But, I'd love to hear that as well. Like, how have you bridged that gap with your patients directly? And how do we help other physicians and patients know that it's okay to acknowledge that this is a real difficulty?
Yeah. A lot of what you said, Chris, like my wheels are turning. I'm trying to think in boxes of, and deconstruct that. So firstly, I think I would say that it's a highly charged experience, like even experience for a patient and an oncologist when you first have that first consultation. And so if we think about trying to convey and engage a patient and them understanding, we all kind of have to go in knowing they're in a really stressful environment. And I'll come back to the COVID thing just because I think this really kind of, COVID made it hard because we had to have patients come by themselves, which is just brutal. Like it just added this extra layer of, they don't have an extra set of ears or a support person or someone with them. And I think for me, that really, I learned a lot from that. There are things I took for granted before that made me kind of, how you come back and say, well, we need to do this differently. And so the one thing is I always encourage patients, bring someone with you, right? Because I think that extra set of ears, if that's possible, really matters. The second thing is I've learned a lot from training residents, and you watch them and how they speak to their patients, and you're like, and your patient, you're watching the interaction, and it's so easy for our young trainees to kind of, again, they're nervous and they default to terminology, and you can see the patients nodding, but they're nodding out of politeness, not really because they understand. And so I think as we train, physicians and healthcare, front patient-facing healthcare workers, I think we learn a lot about how we should engage, because I think everyone has their own style, but it's really important. And I think what you said is about making sure that we have enough time, so that we're not rushing that interaction, so that we can, make sure that if a patient comes back to you and says they didn't understand any of it, and you have to start back and explain it differently, that you have the time to do that. And I think from a patient perspective, if I was a patient watching this, I would say insisting that there be enough time, like not feeling so rushed that you don't have an opportunity to ask the questions. Because I've seen that sometimes where patients will then, call me like the next day saying, I didn't understand any of it. Like, even though you kind of went through it, I'm like, we need to go through that again. And that's okay. That's, sometimes you have to break it down. I think, when I was the nice thing about the TED Talk format, I'll come back to that because I learned a lot of that, is it's you have like 15 minutes and you have to try to convey an idea or a sentiment in a way that's, relatable, hopefully. And I don't know how relatable mine was to most people, but I think it was really anchored on this idea of what can we do as patients to navigate and direct our cancer journey. And one of the big things was about kind of had this thing, the 3 C's of cancer: control, curiosity, and courage. And the control part was about trying to, like, take control of what we can control, because it feels like such a powerless situation when we face cancer, and when a patient, they may feel like they don't have power, but they really do. And probably equally important, if not more important, was the curiosity piece, was really trying to convey to public and patients that, for me, as an oncologist, if you're curious and you're asking questions and wanting to learn, to your point, Chris, it helps for me to know that, okay, you're understanding it, or where are the gaps and how am I being less clear? And B, I think that I've often had situations where patients have asked a question that has really meaningfully altered our, we've said, oh yeah, that's a really good idea, or I don't know, but I need to look that up. And I think that is just, when a patient says to me, I don't have any questions, I'm like, oh, I'm in trouble, because I haven't, this has not gone, I have not communicated well. Yeah.
I couldn't agree more. I mean, if somebody's sitting silent, it usually means that, like, there's a huge disconnect. And that's always when I'm most concerned, even talking to friends or family who are dealing with complicated medical issues. If they don't have any questions, it means that they don't understand the complexity of what they're dealing with usually. I'm really interested, though, in kind of how the TED Talk and all of that process has impacted your day-to-day now. Like, has this become a funded area of research? Is this something that, there's more of a broad goal, either in your institution or maybe across the country, for people to really dive into a bit more? Because obviously we at One Cancer Place, I think we all believe that there's a huge need to improve that communication. And part of the way we're thinking about it is maybe there are some patients who are just going to be more curious and more capable of picking up complicated ideas. Maybe they have a background in science or biology or whatever, and maybe they can help other patients by framing that in a way that is a little bit closer to their perspective than what we as doctors might be able to frame up. So maybe you could talk about sort of where it has led, or maybe it hasn't taken you as far as you would hope. I don't know. How are things going?
I think it's a starting point for the conversation. And so I use the TED. I've given patients the link. I have a QR code, and I'm like, I want you, when the first time I meet them, now a lot of patients have come in, and how patients will Google you, right? They'll Google you and say, oh, I saw your TED Talk. And to me, it's like, it's very gratifying when a patient comes in and they're like, I'm ready to ask questions. And they said, I saw your talk, and I swear to God, I was like, oh my God, that was the intent, was that people would feel like this was, I don't want to say permission, but an entry for them to say, hey, this is how we should be. We need to start our relationship. I also think that from a fund, like, what are institutions doing from a communication perspective? I think one of the things that, again, I'll come back to kind of COVID learnings that we've realized is that how care is received is quite inequitable. And one of the drivers of equity and access really is a patient's ability to be able to advocate and access, for themselves. Because and the folks that are most vulnerable are marginalized populations, or so whether it's because of language or socioeconomic status, or not being able to, understand like you said, the complexity of what's going on, and they feel quite intimidated to ask and advocate for themselves. So we have in Canada, our marginalized population in healthcare that's really come to the limelight has been the Indigenous population. So we have introduced now patient navigators, Indigenous care navigators for patients who self-identify as Indigenous, and they will come with them to the appointments. And really, will try to help facilitate this. Are we understanding each other? And I think patients need to have support to be able to advocate for themselves. I think we all, like, you raise a really good point. We can't put it all on the patients either and say, hey, look, you need to come like super sophisticated and have done all the research, and we want you to advocate for yourself, and then put this pressure that, oh, no, it's all on you. The system has to facilitate that advocacy, and that starts from equitable access, and it includes things like no question is a bad question, or not dismissing patient questions as well. Like I think we have a lot to learn. I don't think of myself as a perfect communicator. I learn every day about something I could do better. But I think there are, to your point about putting resources to it, I think that is an unmet need. And maybe one of the things we should be thinking about as academics is more research into how does patient advocacy and empowerment potentially influence outcomes. If you could kind of, if there was some data to support that, and that outcome doesn't have to necessarily be like a traditional clinical trial outcome. It can be about patient experience and quality of life. And we know those kinds of patient-reported outcomes have real value in healthcare.
Yeah. A couple of things you said, just trigger some thoughts for me. One is that I think one thing that is kind of I see these groups of, or at least I used to see these patients in terms of groups of like way that they engage the interaction with their physician. Like there's the group that very, very smart people, and maybe don't want to admit the things that they don't know, thinking like, oh, I can find that on the internet. I don't want to show up unprepared. I want to be ready. I want to like have the answers, right? And that's a little bit dangerous in and of itself, because if you can get all the answers that you need to manage your cancer by searching the internet, then like we really don't need to go to medical school and then spend an additional 6 years of training to be able to engage in these topics. And like you said, it usually takes many years after that for people to become really, really good at what the specific subtype of cancer that they treat. So that's, one bucket. The other bucket is people who are just like, I don't know anything. You just tell me what to do. Right. Which is also a little bit dangerous. It's kind of the other end of the spectrum. And I think what we're kind of getting at is if you think that you're either of those groups of people, or anywhere in between, there is a lot of opportunity to still learn and just say, look, I read this. I don't know if this is true or not. Can you help me out? Like, how do I frame this? How do I think about this? Because what I find is that even if people do understand pretty well what you're talking about in a clinic visit, they have to then go explain that to their friends or their family, who are all going to be asking them a bunch of questions. And before you know it, somebody asks a follow-up question that they can't answer. And then it's like, oh, the whole treatment plan is being called into question. And do I really trust my doctor and all of that? And I find that whole series of events like just so stressful on patients. Just so overwhelming. And I wonder if like through the TED Talk and bringing this topic to light, if people have come to you and just sort of shared like that emotion that they feel when they are starting out on this journey, or even maybe 2 or 3 years in, realizing, man, I didn't know anything 2 years ago. Now I can't believe, I wish I knew then what I know now. Right? Has that happened?
Interestingly, a lot of that kind of feedback hasn't come from patients, but from colleagues, and about sharing kind of what we like the theme resonates. Like I kind of said earlier, if you're a clinician, at the heart of it, that this is important. But and how important, and so there's kind of, I think it's brought for me a group of like-minded colleagues. And, when I first did the talk, I shared it with, ASCO has this Women in Oncology network, and I shared it with them, and I managed to connect with a lot of other oncologists who kind of have a similar mindset. And we were like, we need to think about how do we we advance this science of understanding patient advocacy and its importance in cancer care in particular? I wanted to come back to this, the patient descriptions you described. I think I will often start my conversation with patients with you're driving this bus. I am going to try to be your navigator, like your ways for your journey, but you are in the driver's seat, and I want us to have like shared decision making, and I agree with you. Those two extremes of either where a patient doesn't want to share the decision making because they feel like they already know the answer, which I think is less common. Maybe it's a Canadian thing. That's less common in my practice, versus patients who are totally be like, well, whatever you say, doc, which I get a lot. And I try to kind of reframe it. So I do, I think, when patients come to us, it's our role as providers to set the ground rules, and those ground rules need to give permission for this idea that it's not, I'm going to be telling you what to do. And as we all know, different patients come from different cultural backgrounds, have a very different perspective about healthcare and what the doctor's role is. And some can be almost too deferential, where they'll be like, whatever you say. And then but I think that sweet spot is that where we are truly making decisions together. And I think that, we can't be dismissive of the fact that we are the content experts in that interaction. Mm-hmm. But at the same time, we should be ready to say, I don't know, as oncologists. We should be we shouldn't feel threatened if a patient asks a challenging question that we don't know the answer to. I say, I don't know, every day. I'm like, that's a really good question. I don't know. And I've yet to have a patient say to me, wow, you're supposed to be the expert, me feel like I've suddenly lost my credibility, so I think it goes both ways, but that conversation can only happen if we are open to recognizing that, when patients this is their life on the line. They're going to find stuff that you probably don't know, right? They've looked up things, and patients will send me papers, and I'm like, we have to have humility to say, there are things that are going to come up we don't know. And let's see if this applies. And like you said, have a discussion that's respectful and not dismissive, and say, oh, look, I'm going to shut this down, because we don't do that,
Yeah. No, I think it really is a population dependent thing, where you'll find small pockets of people who, believe they already have some answers when they show up. It's definitely the outlier, I would say. I think more commonly, I don't know about you, but every time I met a patient that was new to me, my first question was, what is cancer? And to them, right? Not like, tell me your history and all this stuff, just like, tell me what cancer is. And I would say maybe 1 out of 3 or 1 out of 4 patients had something already in their head of like being able to describe what the pathology of cancer is. Mm-hmm. Which is kind of alarming when you think about it, because I was only seeing patients toward the end of their care, almost exclusively, right? Mm-hmm. So most of the patients I saw had many years of treatment and different doctors and all of that. And if I just said, like, well, if you had to tell your cousin or your mom or your dad, like, what is the thing that is going to kill you or might kill you? What is it? And like, the fact that more than half of the patients just couldn't describe that in layman's terms makes it really hard to come up with a scenario where they could make an equal weight decision with me, right? It's very hard to like say, I'd like to do this because of this, if you don't know what the thing is that you're dealing with at all, right?
Yeah.
So like we would always often start with that, because I felt like if first my first thing is going to make sure that we're on the same page about like a very basic understanding of what the thing is that we're dealing with.
Yeah.
And if we couldn't get there, then like, okay, if you want to just hand over all decision making to somebody else, fine. If that's all you really want, okay. But I do want to give it the best shot that we can at least have this conversation. And I don't know about you, but I found that was a really rewarding way to start our conversations, starting with what is cancer, and then what are you hoping to have be the biggest thing that happens in your life, the rest of your, whatever it is. Like, what do you hope to have happen? Like, do you want to be cured, or do you want to live to a certain period of time? Do you want to be like, feel as good as you can, as long as you can? Like, let's talk about that. Because those are the things when we talk about mutual decision-making, that is not my decision at all. Like, I don't get to impose my values on what somebody else wants to do. I can just do my best to try to get them there. And that's what I found so compelling about your talk is I think that should be the overarching message when anyone starts oncology training is like, let's make sure people know what they're dealing with, and let's make sure we understand what they want to achieve. And then let's work from there. Yeah.
Yeah. I think, at my, I like that approach. I'm going to probably use that at some point. I often start off with what is your understanding of your diagnosis? And, they're in a cancer center. They know I'm a cancer doctor. And many, many times, I won't say the majority of the time, but easily maybe 30, 40% of the time, nowhere in their sharing of their diagnosis of what they know will they use the word cancer. Like, people will say there's a tumor, or there's something there, or they found something. And so one of the things I kind of talk about in the TED Talk was about, let's just own this word cancer. Like, let's not, I think there's, and understand that, this is not, like in the Canadian cancer statistics, and I'm sure similar in the US, is like, 1 in 2 to 1 in 3 people are going to face a diagnosis of cancer in their lifetime. So we should have an understanding of what it is. And I think the point about what matters to you, like, like, what are your goals here? What are you hoping, to achieve will happen? I think that is like, it's so important. And I think from a patient perspective, I think about taking my mom to an appointment and things like that. It's like, it would be hard for her to articulate, and so you really have to do some, honest reflection about what does matter. And some people will say, my daughter is having a baby in December and I need to be there. Right. And and that really helps me to kind of anchor our discussion and sort of say, this is about you, like you said, not about what I think would be important for you. And, I'll go, patients will, an informed patient, like, I can tell, like, in the first few minutes of the interaction that this is going to be a ride, like, where they, notebook, they're recording this. And I love when patients honestly record our discussion, because it actually answers a lot of their questions. They get to hear it again. They're ready to go. And in Canada, we have a public health system. So everything, it's universally funded, but patients will say to me, hey, look, if there is something that I need to pay for, right, that you think would be a better option for me, but it's not part of what's publicly funded, then I want to know, because I'm open to that option. Or if you think I need to travel out of country for a trial, I want to know. And I'm always like, wow, you really like come, curious and empowered. Like, you really are, and I wish that happened more. I wish there could be a way in which, it's hard but we could empower patients, facilitate that kind of curiosity, so people know that they can ask those questions or state those kinds of preferences, or this is what's important for me. And I think a lot of times it doesn't happen.
Yeah. Well, I don't know if this resonates with you, but it seems like the barrier, the initiation barrier of the conversation is so high for people, right? I'll just use an example without defining who this person is, but there's somebody who is in my family who I know that every time they go to the doctor, their anxiety level is like through the roof, being afraid that they're going to use the wrong word in the conversation. And this isn't about cancer. This is just other things.
Oh, yeah.
And they're just afraid that they're going to say the wrong thing and sound silly. And so they say less. Mm-hmm. And then they don't get the answers to the questions that they want. And I don't know how we break that for patients, right? I don't know how we set them at ease enough, other than maybe a way is that as doctors, we could all ask, what do you do? And then say, why don't you use 4 words in your, in the terminology of whatever it is your job is that I would have no idea what they are. I just want to set the baseline that like we all do this, right? Like all of us in our jobs, we are experts at something that most people don't understand. And it's no different. Like if I'm a doctor or you're a teacher or you're, a metal worker, like I have no idea how to weld something, right? So like, why would I expect you to know how messenger RNA works? Like, it's just not your job, right? So I'm more than happy to explain it to you, but you have to tell me when we're talking about something that like you have no idea what I'm talking about, so that I can take it down or take it back a few levels so that we can talk through it. But I mean, I know just from my own like family experience that is not normal. Most people would rather shake their head yes and have no idea what you're talking about to get out of the room.
Yeah. I think it's this. It's a very high expectation to place on yourself, and I kind of think of like, I think we all do it. If I go to a mechanic about my car and I don't know,
a great example,
and they'll start using terminology, and I'll be like, I don't know, just send me the bill. But I think human nature, I think we all do it. But the difference here is that, like you said, that in healthcare, a patient's priorities, like so many of the decisions about what we do and why we're going to do this and this, have to be driven by, is this meaningful? Does this matter to a patient? I've had situations where, we kind of defaulting to next line of therapy and talk about something, but you come back to that and patients will make very different decisions about what they want and what they want their end of life to look like. And they've really, we can't prejudge or even guess what that's going to be. So here, this is like, it's really important. Your voice is really important as a patient. And I think that's where, groups like One Cancer Place, where sometimes if patients, it normalizes, I think, the idea of I should be asking questions, or look, I'm not, or if I don't understand something, I'm not the only one. And I think that kind of peer-to-peer support and learning can kind of fuel that, the curiosity that they say, you know what, it's okay for me to go to my oncologist and say, I don't know what cancer is. Can you explain it to me, and not feel bad about it? Yeah.
Yeah. I think we hope that these sorts of videos help people understand that is, as an oncologist, I never ever expected someone to walk into the room and start talking about, molecular biology or, cell division attributes or what, like, of course not. But there are some high level concepts that I believe that we need to have in common to have a meaningful conversation about. I do think also that one of the things that's really tough, one of the things we learn in oncology training is understanding risk and reward. Like that is, like very much the driver of the decision making that we do as oncologists. And I, again, was just talking, this is a friend of the family who was just diagnosed with prostate cancer. And I was talking to him about the decision tree that he has for a newly diagnosed prostate cancer. And that's, I used to work on a team that treated primarily prostate cancer. And we were just talking through the scenarios, and his ability to internalize the trade-offs of the decisions that might face him and the risks and the reward. I told him at the time, I was like, this is extremely unusual, right? That you can put yourself, you can say on a population level, there's a 5% chance of this outcome, but for me, it's binary, right? Like for me, it's either yes or no. For 100 people, it's 5 out of 100, right? Like that's a hard thing for most human beings to conceptualize. And I'm not saying that we as oncologists are like more gifted. We just have had a lot more chance to try to internalize that and apply it in our day-to-day lives. Most people don't ever have to think about that, right? Like you said, you take your car to the mechanic. Your mechanic doesn't say, well, there's a 5 in 100 chance that I'm going to get this wrong, right?
Yeah.
There actually is. I mean, anyone who's ever been to a mechanic knows that like they're not going to get it right every single time, right? Like, and that has to do with the skill of the technician and all kinds of stuff. But they never tell you that. It's just like, I'm going to fix your car. I'm going to give it back to you. Yeah. Well, now we're talking about life and death, right? So now every decision is amplified, and it's amplified to the point that people can freeze and feel totally overwhelmed. And I don't know how to convey that, but like, I think that is one topic that we will want to take up on this channel is like understanding like really basic statistics, you know, for patients, just like, what does it mean that there's a 5% chance of this? And what does that actually mean to me, right? Like, is it a spectrum of outcomes, or is it really just like, if this happens, it's bad, and if it doesn't, it's good, or what? So,
it's, you know, I think of like, I treat GI, so I think about adjuvant treatment of is a really good example of, you know, patients have had surgery and they're like, oh, my cancer's gone. And then you're trying to explain, you know, risk benefit. And so you're like, you know, and as you said, that, you know, the trade-off of 3 to 6 months of chemotherapy and related toxicity to some kind of future benefit, because they feel fine now. And you're, you know, so you will use like, try to use number needed to treat, or for like every 5 people who get this chemo, only 2 actually benefit from it. You know, but it's really, it is a challenge. I mean, I think, and I oftentimes, patients will just be like, the default is usually yes, because it's weighted by the fear we think of related to cancer, right? And it seems, and it's so ominous that people are like, I will do whatever. And when we consent patients for chemotherapy and the related toxicity, I really do sometimes wonder, are they really understanding or appreciating like what this means? You know, but I think that is the best example of how hard this is, right? In breast cancer and colon cancer are probably the 2 best examples. Prostate cancer is right there for certain decisions, but they're very specific. But in breast cancer and colon cancer, most people probably don't know this, but you know, if you're diagnosed with a stage 2 breast cancer or colon cancer, the hardest choice we have to make is to decide how aggressively to treat you, right? That's the hardest decision, because we know if we did nothing for a lot of patients in that scenario, you would be cured. I mean, other than the surgery, right? Other than the removal. Yeah. And it's such a tough decision. There are a lot of tools that have been put in place to try to help make these decisions, but they're not perfect. None of those tools are perfect. And, you know, when you talk about breast cancer, you can talk about the decision of adding an extremely toxic drug or 2 drugs to achieve maybe a 1% difference, or, you know, in some cases of the likelihood of recurrence. And the amount of cost to the individual and to the system is pretty enormous. I mean, I don't think most people fully understand how big of a deal that is. And I'll just give one more personal example here. A family member of mine had to make that decision, took a very aggressive chemotherapy course for, you know, an early stage breast cancer, and ended up having MDS. You know, it's like this is a much bigger problem now as a result of that complicated course of treatment. And I think those are the things that are very hard to convey to individual patients when they come in the door. Yeah. I think one of the, and I mentioned this in my TED Talk because it was important to me, and I had to be very selective about my words, where they were like, you only have this many words because you only have this much time. But I talked a bit about the military types of metaphors we use with cancer, and like you're fighting cancer and it's the war on cancer. And I think in some, that construct can be helpful, but it also can have a downside. And sometimes I think people feel like they have to do everything that's offered to them. They have to do it. Like, it's just this, and we try to present things as a choice, not as a you have to, like based on, what are your preferences and what's important for you. And if truly 1% is meaningful for you, then that's the right decision. But if it has to be, in the right context. And I think this then comes back to patients being comfortable, asking the question, like you said, if they don't understand it, what does that mean? And what if I don't do this? And it's okay, obviously, there's, in any situation, we make decisions based on the best information we have. And at some point, a decision needs to be made. We can't kind of like perseverate on it for a long time. But I think that is, it's really important to know, like for colon cancer, it's like the big oxaliplatin related neuropathy. And so if you have a stage 2 colon cancer and you're talking about, and I really try to be like, it's no joke. And they're like, oh, it's not. And then 1 year, 2 year, 3 years later, they're cancer free, but they can't, their walking is limited, or they're like, I can't play the guitar anymore. And that's really important for me. And you feel like, wow, it's, I hear what you're saying, Chris. It's, these are challenging and situations, but I think, for oncology, I think there's always going to be this, people being worried about sort of regret. Like patients will say to me, the path of least regret. And it would be like, if the cancer came back and I chose not to do it, even though I know it would have made a marginal difference, I'll never forgive myself. So I'm like, okay, that's all right. Actually, when patients say that, I kind of feel like they really, they understand the trade-offs and what we're talking about. And that is, that's fine. But I think that's what it is. It's kind of like the path of least regret is to do more now versus, potentially face a recurrence later. And we need to be better at trying to make people understand, what those trade-offs are.
And I think the reason that is so difficult is that if that patient did a little less and their cancer came back, we actually don't know that doing more would have kept that cancer from coming back, right? And that's something that is like the path of least regret. And I don't mean this just about cancer, but the path of least regret is a terrible way to live your life, right? It is because you can regret anything, right? Like there are so much uncertainty. I did want to clarify one thing just for the audience. So I said MDS earlier. MDS stands for myelodysplastic syndrome, and it is actually a bit of a catch-all term that can encompass a lot of underlying pathophysiology, but it can happen after high-dose chemotherapy. So what it means is that the bone marrow essentially isn't functioning normally, and there is some reason for that is oftentimes very difficult to explain. And then to treat it or cure it, you're either becoming sort of transfusion dependent and growth factor dependent a lot of times, meaning you're trying to get certain immune cells to reawaken. But sometimes it's actually like an autoimmune attack on the bone marrow. Like, it's very complicated biology. So anyway, the point is that these things sometimes it's directly related to the chemotherapy itself. So the point here is that these sort of like extreme complications are not as rare as most people think. Mm-hmm. They actually happen in the real world a fair amount of time. And by fair, I mean, 0 to 5% of the time, you'll have some complication that is a long-term complication of high-dose adjuvant chemotherapy, right? And just for anybody who doesn't know these terms too, adjuvant means like after surgical removal, you're giving chemotherapy to kind of eliminate the last microscopic cancer cell. And when you think about what you're trying to do, you're trying to hit it as hard as you possibly can because you're trying to cure it. And so in colon cancer, oxaliplatin tends to be the biggest offending agent. It causes nerve damage, and it is a very difficult drug to give repeatedly for a long period of time, and the toxicities mount. And in breast cancer, there are similar drugs that the longer you give them, the more the impact is on the bone marrow and some other things. So we don't need to get into all of that detail for this conversation. My point was that if you could take each patient and walk them, you could do like a ghost of Christmas future, right? Like, and you could walk them through like, hey, here are the 1,000 scenarios you face. And this scenario might only happen 50 out of 1,000 times, but it's a really bad outcome. And it includes curing your cancer, but it could still be terrible. Most people just don't have that in mind as a possibility, I think. And it's something I think we have to work really hard on as a community of oncologists, but also as people who want to help patients make better decisions with their friends who are patients now, right? It's a lot. Yeah. It's a lot of hard decisions.
Yeah. And I think, one of the things that I sometimes, if I was going to say, I believe strongly in is having your team, right? And so sometimes if I felt I couldn't self-advocate for myself, then finding somebody who can be your voice, your champion is really important, like recruiting like help. And so sometimes, as I mentioned, when we're having a discussion and for a patient, they're like kind of just, it's like they're no longer engaged in the conversation and overwhelmed. It's the support person, whoever that might be, who often will help prompt questions or ask questions. And sometimes if a patient says they have no questions, I'll be like, well, a lot of patients have this question. Is that a question for you? Or a lot of patients might, and I think it does behoove us to really try to continue to kind of open the door for a patient. And then if someone will get more comfortable and say, yeah, actually, I was thinking that. I find that that's a good entree for me to kind of go in and sort of poke them a little bit and not make them feel bad that they didn't think of a question, because I don't want, you don't want to create that pressure. But, I think, how this is, how we support, patients through that, even in terms of like how our clinics are physically set up and how we are speaking to patients and, what kinds of, tools we have to explain what's happening to patients. I think I try as much as I can to, when I'm having a conversation, like, and I think we all do that, pull up scans so they understand what's going on with them, personalize it so they know what we're talking about. And, and I think it makes people feel more like, it's important. The message I'm trying to convey is it's important for me that you understand, right? That, and I need your help. I'll often, use that word. I say, I need your help for us to make the best decision for you together. And I hope that patients receive that in the way it's intended, which is not to put pressure on them, but to say that, your voice is really what's going to drive, what we do. I think, and sometimes that also, I will also start with, questions about, are you a numbers person? Because sometimes patients don't like numbers. When we talked about sort of adjuvant treatment, and you said risk reward and trying to put numbers around that. Sometimes people don't want to hear, at least, until you get to know them, they don't want to hear the numbers. So and easily a few times, a week, someone will say like, I don't want to know the numbers. I want a general idea. So, we trying to just really understand how a patient wants to receive their information is important. And other people will be like, yeah, I love the numbers. And then I'm like writing down numbers for them and they really, get into it. So, but not everyone is like that. I learned that the hard way because I had a patient who was really turned off by their risk of recurrence. Like I went into, okay, you have this, and with surgery alone, when we think about what we're trying to do for adjuvant, this would be the risk. And they were like, really, they didn't expect what I had said. And I just realized I kind of walked into a situation where I should have really kind of, explored more, what was really their understanding. I think they kind of, and so now I always ask, I'm like, do you want numbers? Are you a numbers person?
Yeah. Yeah. I mean, I think if we are trying to boil down, though, some of the things we're saying to like some simple messages for patients, like that they can carry with them if they were just diagnosed, or even that, they could pass along to other patients in a similar situation. One is like, try to understand what your target is. What are you aiming for? Are you aiming to be cured? And if so, your first question to your doctor should be, is this generally considered curable, right? It's not like, am I going to be cured? But like, is there a chance based on, what you know about my situation? Is that chance okay? Or is it like very unusual to be cured? And if it's very unusual, then you go down another series of questions, right? Like, okay, well, I think the whole, like, how long do I have to live is not a great question. I'll just state that. It's nobody knows. Yeah. Nobody knows, but you can tell you medians of populations of patients that look like you, but they cannot tell you what will happen with you. And so what I think you really want to do then is say, listen, I think there are a lot of things that we're going to have to make decisions about, but I want you to know a little bit about me and what I care about, so that we can frame that up and we can have the right conversation if it gets to a hard conversation. Because for the most part, the first thing that you do as a patient is going to be pretty straightforward for most cases of cancer, right? Like, the thing to do in that situation is usually fairly obvious to an experienced oncologist. But it's what happens after that first treatment that sort of changes all the different paths after that. And that's why you have to build that relationship during that initial treatment phase. You have to let your doctor know what you care about, or they're not going to think about what you care about. Yeah.
Yeah. And I think that, the takeaways are kind of, I'll come back to the sort of the 3 C's thing that I kind of had put in my mind as a framework for the TED Talk. So the take control about, also does speak to this idea of driving the agenda, right? Like you said, what is important to me, and why am I here? Like, why did what do I want to get out of this? And as I said, those goals, you have to, it takes some self-reflection to think about, what it is that you want. The curiosity, be curious, no question is a bad question. Ask questions, tag someone to ask questions for you if you can't be the one to ask questions. But, it's a desire to want to learn more and not be afraid of what that information might be, because I think that, knowledge is power. We all believe that, and we know it. And sometimes people have to come to that on their own time, but being curious and learning as much as you can, and not saying become an expert oncologist, but enough so that you're able to kind of be able to make those kinds of decisions and trade-offs. And then the last one was, have courage. And that's not meant to sound trite, but it's meant to say, sometimes these are difficult. They're going to be difficult conversations, and not shying away from those difficult questions and those difficult conversations. I know you said, I struggle with the question about how much time do I have? I think patients, but when a patient asks me that question, it can veer towards, you can try to kind of drill it down. They've opened the door to, hey, look, how am I going to do? What are we looking at here? And sometimes I'll ask them, well, what do you think it is? And so many times patients actually have a really good understanding of what's going on with their cancer. They're just not prepared to say it. And say
it out loud. Yeah,
say it out loud, or maybe they're hoping I'm going to say something different. So I'll often say, well, okay, I know what, you want to understanding of how things are going or where things are. What do you think is going on? And the majority of the time, they know the answer to their own question.
Right.
And so I have, like I said, I have benefited so much from what patients have taught me. Their experience has benefited my future patients, because I'm always like, hey, look, I had a patient and they were like all over it. And this is, it really helped them. I will use patient stories to help people, figure out what kind of patient, how they want to drive that journey. And again, I think so advocacy networks, One Cancer Plays, whatever it may be in your community that helps you connect with other patients and understand that perspective and what has worked and not worked for other patients is also, so vitally important.
Yeah, absolutely. Yeah, I think just to add on one little point here to something that you just said that triggered this thought for me is like, part of the problem is some of the words that we use as oncologists and researchers. And I think one example is, if you're looking through like a tweet about like the outcome of a drug. Let's take regorafenib, like a drug you and I both know fairly well for its strengths and significant weaknesses, right? Someone would say, well, the difference in like progression that you're going to get out of this is only a couple of months, right? Like it's not that big of a deal.
Yeah.
And that is just such a poor understanding of statistics that it actually leads to confusion for patients, right? Because yes, for 100 patients that are identically matched in a population, this group might only have 2 months better median outcome compared to this group or whatever it is, right?
Yeah.
But that actually doesn't matter, because what we're actually asking is, does this drug work in some fraction of the patients well enough that it changes the outcome on a population level? And that's such a hard concept to understand. But what we really want to know is, for the patients it works for, does it work well enough to be usable, right?
Or worth using. Yeah.
But the thing is, when people Google this stuff, what they see is it changes the progression-free survival by 2 months, right? Well, that's not true, right? I mean, it is true on a population level, but on a person-by-person level, it only matters if, does this drug work for you or does it not, right?
Yeah.
And so I think part of it is that, like, we use this language in this like colloquial way of talking to each other as oncologists because we just kind of know what we mean by it.
Yeah.
And it's so confusing to patients what that actually means.
Yeah.
And there's 100 other examples like that, but that's just one that I know I've heard from patients so many times. Like, why would anyone use this? It's only this delta, and it's like, well, not exactly, right? Like, that's not exactly how it works, but we had 8 years of training to understand.
Yeah. I mean, statistics are, they're, they have their place in sort of, when we critically appraise, or, we're evaluating something, but on an individual at the bedside discussion, it's really limiting. And we always kind of struggle when you're teaching residents about how do you explain this benefit, to patients. I do think that, I think academia is, getting the message. We, more and more in oncology, we're kind of talking about landmark analyses. How many patients are alive at 2 years and 3 years? I find that to be
much
helpful,
much better,
relatable. Median, tricky. I totally share your thoughts.
But I mean, that's one example, but there are lots of them, right? And I think the way we talk about adverse events and things, it's the same way, right? We have to find a better way to characterize it. And I think part of this sort of effort, right, to get these type of ideas in front of patients who want to dive in and understand it, I hope will become a feedback loop for oncologists, so that we can say, like, where did we go wrong there? How can we do that better? Because, we need patients to dive in and try to understand this stuff so that they can say, here's the gap. Here's where I'm missing this concept. It's really not until somebody really tries to lean in that we can find out what we could do better.
No, 100%. Like, I think we we are, you choose medicine because you're a lifelong learner, right? There's what we learned in medical school has very little to do with how we practice today because it's dynamic. And so part of that lifelong learning is also learning, like I said, from our patients. And if a patient if I'm having conversations and patients are saying, look, hey, that doesn't make sense to me, or please explain that. At some point, I'm going to say, I should not be using this, this way of communicating. And I think for those of us who are involved in designing clinical trials and thinking about trials and endpoints that matter, we inform those decisions by our patient experience, right? We're all human. We that's how you kind of think about things. You have the science part of it, and you have what you see every day in clinic, and so I 100% agree with you that I think there is a feedback loop. Maybe and these conversations do matter.
Yeah, but I mean, it seems like that's a great place to kind of wind up the conversation. I want to thank you for, really just going out on a limb to talk about this, right? I mean, this is a tough topic. It's probably not one that most of us as doctors want to acknowledge that we're not great at. So it takes some real courage to go out and bring this to the forefront and try to bring the patient perspective a bit more to what we're all trying to accomplish. So I want to thank you for doing that and putting it into a 15-minute bite-sized, digestible conversation that hopefully stimulates a lot more conversation over time. Any closing remarks that you'd like to leave us with?
Well, I thank you, Chris. I really enjoyed our conversation, and I do hope that there are learnings here for anyone watching this. My motivation for the TED Talk really was about trying to start that conversation, and my hope is that there's something there. The theme of a TED Talk is an idea worth sharing. So hopefully there are a few ideas there that people will feel comfortable sharing, and it will kind of, like I said, advance that conversation and hopefully inform that feedback loop. So we are making really meaningful material differences in how we communicate with patients and engage patients and support patients to be able to be curious and advocate and empower themselves in their cancer journey.
Thank you so much for that. Sarah, I'll turn it back over to you to close us out.
Thank you to all our viewers who joined us today, and a special thanks to our experts, Dr. Chris Heary and Dr. Sharlene Gill. Thank you to our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. We look forward to seeing you next time on Live at One Cancer Place.